Bismillahirrahmanirrahim and Assalamu alaikum. My name is Malaika Iram and today the topic of my presentation is attitude of professionals towards low vision rehabilitation and referral practices. To start with, what is low vision? Low vision is a type of visual impairment in which visual acuity is reduced to 612 or 618 in good eye with visual field less than 20 degrees and it cannot be treated with any conventional method and the person is not able to perform functionally well. What is low vision rehabilitation? Low vision rehabilitation is the use of aids, therapies, and environmental modification through which we maximize the functional visual ability of a patient with low vision so that he can perform the functions of his life independently. So what are the objectives of our study? Our study, the main objective is to investigate the level of awareness about low vision rehabilitation in professionals. And secondly, we want to identify the barriers that affect the individuals and the factor that hinder the effective referral process. Methodology, it is non-probability convenient sampling, जिसके through data जो collect किया गया है. Second, the sample size is 87 with 49 optometrists and 38 ophthalmologists. And SPSS is used to analyze the data. Results, first हमने divide किया था अपने performa को 3 portions में. First 4 questions were about the awareness. Second portion जो 4 questions थे that were about referrals, and the last 4 questions were about barriers that hinder the referral process. So first awareness about familiarity with low vision devices was modest. About 49% of ophthalmologists and 49% of optometrists and 34% of ophthalmologists were familiar. However, the familiarity with intervention, ophthalmologists were more familiar than optometrists. Referral criteria, optometrists, large proportion of optometrists chose WHO criteria for referral. However, a significant proportion of ophthalmologists choose poor vision in both eyes as their criteria for referrals. Lack of awareness was most common barrier according to the both groups. Groups provide intervention, but optometrists were more actively involved in providing intervention than ophthalmologists. These are some tables according to p-values. Conclusion ये थी कि both groups frequently referred patient for low vision rehabilitation, but the problem still remained that lack of knowledge both in professionals and public was there, and it was the basic barrier. So we need to study and effectively we need clear regulation to establish a uniform access to allow public to assess these services properly. Adaptive training and counseling should also be included in the services, in the education process, so that people are more aware and professionals are also more aware about these. These are the references, and thank you.
Muhammad Hassan Owais. His topic is effect of full day work on refractive status of goldsmiths and watchmakers.
Assalamu alaikum. I am Muhammad Hassan Owais. My topic is effect of full day work on refractive status of goldsmiths and watchmakers. Introduction. As we know, these two professions do excessive near work, and by doing excessive near work, they induce transient myopia. Refractive error occur in this case is due to prolonged duration of near work ranging from 1 to 4 hours. The relationship between the development of myopia and the increase in accommodation was thought to be mediated by excessive near work. By causing excessive near work, retinal defocus and axial elongation occur, which in turn cause low degree of axial permanent myopia or myopic development. The The crystalline lens is unable to decrease its power efficiently and quickly under normal conditions after a prolonged near work. Objectives. The objectives were to assess the effect of full day work of refractive status of goldsmiths and watchmaker due to prolonged near work, and to draw recommendation to treat their astronomic symptoms. Methodology. It was a cross-sectional study. Sample size was 93, and data was collected by a handheld autorefractometer. Data was collected after full day work at the start of the day and after 7 to 10 hours of work, and paired sample t-tests were applied to compare the results. Inclusion criteria: subject with the age of 20 to 40 years, they must be goldsmith or watchmaker, as we are studying these two professions, and their working distance should be 15 to 40 centimeters. Exclusion criteria: subject having any ocular pathology other than refractive error or refractive error higher than plus or minus 6 diopters. These were the two tables of watchmakers and errors of watchmakers and goldsmiths. Again, graphs showing the shifts in their refractive errors. Recommendations were simple. They should take preventive measures. They should work in bright setups. They should wear protective eyewear glasses. They should use 20-20-20 rule in order to decrease astronomic symptoms. They should maintain their body posture and head posture and use eye lubricants in order to prevent dry eyes. Conclusion. The finding of this research shows that if we check both groups together, there was no significant variation, as the p-value was greater than 0.05. But if we check both groups separately, so there is a difference, specific difference in their refractive errors, as we studied. So their p-value was less than 0.05. These were some references. And thank you.
Any questions from the audience side?
सर यूनिवर्सिटी ने मुझे प्रोवाइड किया था नाइडेक का हैंड हेल्ड ऑटो रिफ्रैक्टोमीटर. सर मुझे याद नहीं है एग्जैक्टली.
पुराना था नया था?
सर पुराना ही था.
ठीक.
थैंक यू सर.
Aisha Tariq. She will present on obstacles in use of low vision devices in persons with low vision.
Assalamu alaikum. Good morning. I'm Aisha Tariq, optometrist. Today my topic is obstacle in utilization of low vision devices in person with low visions. That majority of the cases, majority of the people जो low vision के हैं वो किन reasons की वजह से devices को use नहीं करते हैं. And हमने भी काफ़ी लोगों को अपने इर्द देखा होगा कि why they don't use low vision devices in their daily life. First of all, we will go through low vision. What is low vision? Low vision is basically a condition in which best corrected visual acuity is less than 6/18 and the visual field is less than 10 degree. And visual field poorer than 3/60 is classified as blind. Second is low vision devices. The devices which are used by a low vision person in order to increase the residual vision by which they can effectively use their functional vision better and independently act and can be inclusive in the society is basically low vision devices. Low vision devices में कम vision होने के बाद भी इनकी residual vision को इस तरह से improve किया जाता है कि वो अपनी daily life activities में independently participate कर सकें. And this is one of the major problem low vision in developing countries. Instead of the devices available and instead of the techniques available, there are certain reasons by which people cannot use the low vision devices. So the objective of this study is to study and identify which are the reasons and which are the obstacles in the utilization of low vision devices by which people are not using these devices. Methodology, the study design was cross-sectional study. 96 low vision people was involved in this study at low vision clinic at New Hospital Lahore in September 2022. Data was collected by using a self-designed questionnaire जिसमें different questionnaire पूछे गए थे and reasons दिए गए थे and yes or no उसमें reason था. वो कौन से reasons थे वो भी हम आगे देखते हैं. The result इस रिजल्ट से हमें ये पता चला कि देर आर डिफरेंट रीजन्स, फॉर एग्जांपल कॉस्ट, अवेलेबिलिटी, फियर, लैंग्वेज बैरियर, अंडरस्टैंडिंग द इंस्ट्रक्शन, लैक ऑफ फैमिली सपोर्ट, लॉन्ग फॉलोअप्स, लैक ऑफ मोटिवेशन, एंड मेनी अदर रीजन ड्यू टू विच द डिवाइसेज आर नॉट बीइंग यूज्ड बाय द पीपल low vision person in low vision condition. These are basically one of few tables. Number one is, can we afford the devices? हमने उनसे पूछा कि क्या सबसे पहला जो क्वेश्चन था वो ये था कि क्या आप इन डिवाइसेस को अफोर्ड कर सकते हैं. 60% आउट ऑफ 100 क्लेम दैट दे कैन नॉट अफोर्ड द डिवाइस. सो फर्स्ट कंडीशन जो मेजर हमें नज़र आई वो डेट वाज द कॉस्ट. सेकेंड वाज के लॉन्ग फॉलोअप्स. जो बेसिक कंडीशन हमने देखी वो ये भी देखा था कि ड्यू टू द लॉन्ग फॉलोअप्स दे डोंट कम टू लो विजन क्लिनिक अगर उनको डिवाइसेस हम फ्री प्रोवाइड कर भी दें. थर्ड जो रीज़न हमने बहुत ज़्यादा देखी दैट इज़ फियर एंड सिग्मा. ड्यू टू वो यूजली सोसाइटी में उन डिवाइसेस को यूज़ नहीं कर पाते थे एंड फील फियर ऑफ बीइंग यूज देम. सो दिस वर द मेजर रीजन्स and 60 male and 30 females were included in this study. सो फ्यू रिकमेंडेशन कम इन फ्रंट के हमें कौन से रिकमेंडेशन या कौन से चीज़ें करनी चाहिए बाय विच हम इन ऑब्स्टिकल्स को या इन रीजन्स को कम कर सकें. एटलीस्ट कि हम थोड़ा सा अपना लो विजन डिवाइसेस को बेटर जो है वो अवेलेबिलिटी दे सकें लो विजन पीपल में, ताकि वो इसको यूज़ कर सकें और अपनी बेटर फंक्शनल विजन को इम्प्रूव कर सकें. तो सबसे पहले अवेयरनेस. लोगों को पता ही नहीं था जो लो विजन के नहीं थे कि वो लो विजन पर्सन है, ड्यू टू विच वो ये समझते थे कि अब जितनी विजन उनके पास है बस उन्हें पूरी लाइफ उसी को ही लेके चलना है और वो इसको इम्प्रूव नहीं कर सकते. तो फर्स्ट वाज अवेयरनेस कि हम उनको अवेयरनेस दें, उनको बताएं कि किस तरह से लो विजन एक कंडीशन है और किस तरह से हम लो विजन में अपनी आइज़ को मज़ीद बेहतर बना सकते हैं, अपनी फंक्शनल विजन को मज़ीद बेहतर बना सकते हैं. सेकेंड, गुड रेफरल सिस्टम. गुड रेफरल सिस्टम इज़ वेरी इंपॉर्टेंट. प्राइमरी अगर आई केयर में आपके पास एक ऑप्टोमेट्रिस्ट है, अब वो आपको लो विजन का बता रहा है, तो क्या रेफरल सिस्टम लिया जा रहा है, क्या रीजंस हैं जिनकी वजह से वो टर्जरी या लो विजन क्लिनिक्स में नहीं जा पा रहे. तो गुड रेफरल सिस्टम हम लोगों ने करना है. सेकेंड, हम लोगों ने लो विजन क्लिनिक्स DHQ लेवल पे लो विजन क्लिनिक्स यूजुअली नहीं है. सो दिस इज़ वन ऑफ द रिकमेंडेशन कि लो विजन क्लिनिक शुड बी बिल्ड अप एट DHQ लेवल. काउंसलिंग हमें करनी है, ट्रेंड ऑप्टोमेट्रिस्ट की ज़रूरत है एंड पेशेंट शुड बी कंसर्न. और फॉलोअप्स का हमें ख्याल रखना है कि हम कितना फॉलोअप्स अकॉर्डिंग टू द पेशेंट नीड हम उनको दें ताकि वो आसानी से आ सकें. दिस आर सम ऑफ द रेफरेंसेस एंड दिस इज़ ऑल अबाउट द प्रेजेंटेशन. थैंक यू सो मच.
Our next presenter is Mr. Asadullah, and his topic is impact of sleeping position on corneal topographic parameters in patients with keratoconus.
Bismillahirrahmanirrahim. So my name is Asadullah and the topic of my presentation is impact of sleeping positions on corneal tomographic parameters in patients with keratoconus. Let me begin with a quick review of keratoconus. Keratoconus is a progressive corneal ectasia that was first described in more than 150 years ago, and we still continue to understand its behavior. The disease affect both the shape and clarity of the cornea, leading to significant low and high order aberrations. As the condition advances, patient can develop complications like corneal scarring or even acute eye drops, and at those stages, the visual loss become quite severe even with the optimal correction. So, recognizing factors that influence its progression is extremely important. A recent large meta-analysis covering more than 7 million individuals across multiple countries estimate the global prevalence of about 138 cases per 1 lakh people. One important thing to remember is that keratoconus is almost always bilateral, but it is also very asymmetrical. One eye tends to be more affected than the other, and the asymmetry is something we focused on in this study. The etiology of keratoconus is multifactorial. There is a contribution from genetics, environmental influences, and biomechanical changes within the corneal structure. Clinically, we see that a large percentage of patients have atopic conditions or itchy eyes, and many have a history of frequent eye rubbing. These behaviors and biological factors interact in a way that can accelerate disease progression. Biomechanical stress plays a major role in how keratoconus progresses. Chronic eye rubbing is one of the most well-recognized mechanical triggers, and it's been consistently associated with ectasia progression. We also know that
Intraocular pressure fluctuates with body posture, and these changes may influence corneal biomechanics over time. So, any external pressure on the eye, including during sleep, becomes clinically relevant. Now, sleep position is something many patients don't consider, but it can have a powerful effect. When someone sleeps on their side or in their stomach, the eye position downward, what we refer to as the dependent eye, can experience prolonged direct pressure for several hours. This sustained compression has been associated with structural deformation and may contribute to the progression of keratoconus in that eye. This prompted us to investigate whether sleep posture is linked to asymmetry we commonly see between the two eyes. Okay, mechanical stress does not just change the shape of the cornea, it also triggers biological responses. Prolonged pressure or rubbing can increase inflammatory mediators, promote keratocyte apoptosis, and enhance proteolytic enzyme activity. All of this contributes to collagen breakdown and stromal thinning, weakening the cornea over time. Repetitive mechanical trauma also increase oxidative stress, further destabilizing corneal integrity. So these mechanisms give a biological explanation for why the dependent eye may show more disease. So based on all these biomechanical and inflammatory pathways, our study aimed to evaluate whether a person's preferred sleeping position contributes to tomographic asymmetry, specifically in the eye that remains inferior during sleep. We assessed this both in individuals with keratoconus and in those without the disease, so we could see whether this effect is unique to keratoconus corneas or present more generally. All right, moving into the methodology, this study followed a cross-sectional observational study conducted between January 2023 and May 2024. All participants were evaluated at Shifa Eye Care Clinic, Mardan. All participants provide written informed consent after receiving a clear explanation of the study procedures. So, all participants underwent a comprehensive ophthalmic examination. This includes best corrected visual acuity for distance and near, ocular motility assessment through cover and uncover test, and full refractive evaluation using retinoscopy. We performed slit lamp biomicroscopy and tonometry, followed by both direct and indirect fundoscopy. Finally, all subjects underwent corneal tomography using Galili J6 system. Okay, the final sample included 90 individuals between 18 and 35 years of age. 40 had no signs of keratoconus and 50 were diagnosed cases. Based on power calculation to detect 1 minus diopter difference in steep K with 95% power and a significant level of 0.05, a minimum of 44 participants were required. Our sample comfortably exceeded this requirement. To be included, individuals had to be between 18 and 35 years old. Participants in the non-keratoconus group required normal tomographic indices, including a keratoconus probability index 10%. The keratoconus group included grade 1 and grade 2 cases according to the Amsler-Krumage classification. We excluded anyone outside the age range or with the inflammatory or infectious ocular disease based on clinical history and exam findings. Patients with prior ocular surgery or those who were using contact lenses on the day of examination were also excluded. To assess sleeping habits, we used the validated questionnaire by Kim and colleagues. For participants who slept laterally or in the prone position, we added an extra question about head rotation direction. This allowed us to accurately identify which eye was dependent, that is, the eye position downward during the sleep, and which was non-dependent. For statistical analysis, we used SPSS version 25. We compared the dependent and non-dependent eyes within individuals. Qualitative variables were summarized using means, standard deviation, medians, and confidence intervals. The Shapiro-Wilk test showed that most variables were not normally distributed, so we used the non-parametric Wilcoxon test, maintaining a significant level of 0.05. We also considered the effect of multiple testing. Applying a straight Bonferroni correction would lower the threshold to 0.003, where only sin K remains significant. However, based on the arguments by Armstrong and Perniger, Bonferroni is only suitable in specific scenarios such as universal null hypothesis or repeated testing of the same variable across subgroups. which is not the case here. Thus, Bonferroni was deemed inappropriate. Now coming towards my results, this table summarizes the basic demographic characteristics and preferred sleeping position of participants with and without keratoconus. We included 40 individuals without keratoconus and 50 individuals with keratoconus. In terms of gender, the keratoconus group had more females compared to the non-keratoconus group, and this difference was statistically significant with a p-value of 0.045.
ओवर टाइम हो गया इसका
The average age was comparable between the two groups, around 28 years in non-keratoconus group and 26 years in the keratoconus group, with no significant difference. Next, we looked at whether participants had a preferred sleeping position. We found that most participants in both groups reported a preferred position. In comparison, the non-keratoconus group had a very similar pattern with slight variation. Overall, this table shows that majority of the patients, both with and without keratoconus, have a consistent sleeping position preference, and the type of positions are comparable across the two groups. As you can see in the participants without keratoconus, there was no significant difference between the dependent and non-dependent eyes or any of the corneal parameters measured on Galili G6. This indicates the sleeping position did not create a measurable interocular asymmetry in healthy corneas. So overall, this table clearly demonstrates that in individuals without keratoconus, the preferred sleeping position does not produce detectable tomographic differences between the two eyes, and corneal asymmetry is preserved regardless of the dependent side. Now, let's look at the findings in patients with keratoconus. This table compares the dependent eye, the eye that remains inferior during sleep, with the non-dependent eye. In keratoconus patient, both steep K and SEM K were significantly higher in the dependent eye. Steep K was about 2 diopters steeper, and the SEM K showed a similar magnitude of difference. There are strong indicators that the dependent eye tends to show more pronounced ectatic changes. Finally, among individuals without keratoconus, none of the parameters showed significant interocular differences. This reinforces the idea that normal keratoconus corneas tolerate mechanical pressure during sleep without developing asymmetry. This supports the hypothesis that habitual sleeping position may contribute to asymmetrical progression of keratoconus. Here in this is last slide. Here in the figure 1, we can see the tomographic differences between the dependent and non-dependent eyes, both with and without keratoconus. So in figure A and B, in keratoconus patient dependent eye show significantly steeper keratometry. Steep K increases about 2 diopters, and SEM K increases by a similar amount in dependent eyes. This means the eyes on the sleeping side tends to be more corneal steepening and progression markers. If you look at figure C and D, the dependent eyes also show significantly thinner corneas, both at the thinnest point and centrally. This suggests that mechanical pressure during sleep may contribute to localized corneal thinning in keratoconus. If we look at E and the CLMI, which is cone location and magnitude index, are higher in dependent eyes, but the difference is not statistically significant. However, the trend is still support greater cone magnitude on the sleeping side. In figure F, again, dependent eyes have higher asymmetry, although not statistically significant. This indices indicates that a pattern greater ectatic deformation on the dependent side. So finally, in non-keratoconus individuals, none of these parameters were significantly different. This shows that sleeping position influences corneal shape mainly in the eyes that are already biomechanically weak. Thank you.
Thank you very much. Any questions?
आपने कोई एडवाइस भी दी है इन पेशेंट्स को?
एडवाइस तो ये सर कि आप थोड़ा सा मतलब अगर प्रोन पोजीशन यूज करें या एक साइड पे ना लेटे तो बेहतर है सर.
जी, नेक्स्ट प्रेजेंटर इज सलीम खान. सलीम खान अवेलेबल है? अच्छा, ठीक है. एंड हिज टॉपिक इज मायोपिया एंड इट्स एसोसिएटेड रिस्क फैक्टर्स.
Bismillahirrahmanirrahim. I am Salim Khan, working as optometrist in DHQ, Tang. Today I will present my research that was published in PGO. Prevalence of myopia and its associated risk factors in madrasa students in district DI Khan. Many studies are conducted to determine the prevalence of myopia in schools. There are many madrasas in Pakistan. This study conducted in madrasa to determine the prevalence and its associated risk factors of myopia. Methodology. It was a cross-sectional study conducted in selected madrasa of district DI Khan. Two-stage sampling technique was used. In stage 1, 43 strata were identified by probability proportionate to size method. In stage 2, 44 students from each stratum were identified by simple random technique. Refraction was performed by retinoscopy. Interior and posterior segment was examined by optometrist. Chi-square test was used to analyze the prevalence of myopia according to gender and age. Logistic regression was applied to outdoor activity, reading distance, continuous use of electronic gadgets, and sleep duration. Results. A total of 1,750 students were examined. Visual impairment was found in 14%. The most common cause of visual impairment was refractive error. Myopia was the commonest refractive error, 11.1%, followed by hyperopia, 4.2%, and astigmatism, 1.6%. This table shows the common causes of visual impairment, in which refractive error was the main cause by 12.9%. This table shows the most common refractive error, in which myopia is the leading cause, 11.1%. This table shows the gender effect. Prevalence of myopia was high in female, 12.8%, as compared to male, 10.4%, but the difference was not significant. This table shows the age effect. Prevalence of myopia significantly increasing with increasing age. Outdoor activity had no significant effect. Odds ratio is 1.2%. That was a surprising result. This table shows the distance between the eye and book. Prevalence of myopia significantly increases with shorter working distance. Odds ratio is 0.35%. Sleep duration significantly affect myopia. Odds ratio is 1.9%. Continuous use of electronic gadget, myopia increases with increased use of electronic gadget. That was expecting result. Odds ratio is 0.492%. Study hours in madrasa significantly affect myopia. Odds ratio is 0.40%. Conclusion. The present study found that refractive error is the main cause of visual impairment, while myopia is the most prevalent refractive error. Prevalence of myopia is greater in female and directly related with age. The study also concluded that prevalence of myopia increases with shorter working distance, less duration of sleep, more study hours, and continuous use of electronic gadgets. Thanks. Any question?
ये मद्रास में गैजेट्स काफ़ी यूज़ होती हैं।
सर इसमें ज़्यादातर स्टूडेंट ऐसे होते हैं जो घर जाते हैं वापस, तो घर का उनका डेटा लिया है कि घर में आप कितना वो यूज़ करते हैं।
अच्छा, ये कितने परसेंट होते हैं जो मदरसे में रहते हैं और कितने परसेंट चले जाते हैं, कोई है आइडिया?
सर ये एज के ऊपर है, जो 10 ईयर से कम है वो तकरीबन घर जाते हैं, और कुछ मदरसा ऐसे हैं कि उसमें घर नहीं जाते, लेकिन आई थिंक 50% से ज़्यादा हैं जो घर जाते हैं।
जी
जी, थैंक यू वेरी मच।
ये कुछ स्टडीज़ के उसमें कम है, कुछ स्टडीज़ जो हुई हैं उसमें 27% शो हुआ है, लेकिन उनका जो है डेटा वो कम था। हमने तकरीबन 1750 स्टूडेंट्स में, टोटल मदरसा जो हमने किया उनमें 25,000 स्टूडेंट्स थे, जिनमें हमने 1700 ये सैम्पलिंग की।
आपने रेटिनोस्कोपी परफॉर्म की थी, वो साइक्लोप्लेजिक थी या नॉन साइक्लोप्लेजिक थी या मिक्स्ड थी?
10 ईयर से जो कम थे उनको साइक्लोप्लेजिक किया था। सॉरी मैंने वो mention नहीं किया।
थैंक यू।
सॉरी ये ओवरऑल मायोपिक है 0.5 पर डायप्टर, अपर तो 10 डायप्टर तक भी थे। चीज़ें हैं जो इधर मिस की है।
थैंक यू वेरी मच सलीम खान, बहुत शुक्रिया आपका, बहुत अच्छी प्रेजेंटेशन। अच्छा, our next presenter is Miss Aisha Tariq, and her topic is obstacles in utilization of low vision devices in persons with low vision.
ये मेरे ख्याल रिपीट हुआ है।
एक यूज है, यूटिलाइजेशन है, मैं सेम ही है। अच्छा चलें, ठीक हो गया। नेक्स्ट इज काशिफुल्ला। काशिफुल्ला आई थिंक सो अवेलेबल नहीं है। नेक्स्ट प्रेजेंटर इज मरियम फैज, and her topic is prevalence of myopia among rural and urban children in Chakwal under PEAK project.
Assalamu alaikum. My name is Mariam. I'm an optometrist. My topic is prevalence of myopia among rural and urban children in Chakwal under PEAK project. बेसिकली पीक प्रोजेक्ट क्या है? एक पीक प्रोजेक्ट है जो गवर्नमेंट ऑफ पंजाब की तरफ से है। ये पंजाब के अंदर जो कम एरिया, जहाँ पे रूरल एरिया या अर्बन एरिया जहाँ पे इतनी फैसिलिटीज़ नहीं होती, वहाँ पर एक प्रोजेक्ट होता है जिसके थ्रू हम जो ऑप्टोमेट्रिस्ट होते हैं वो पहले एक ऑप्टोमेट्रिक क्लिनिक होता है जहाँ पे सबसे पहले स्क्रीनिंग होती है, ठीक है। देन आगे से सेकेंडरी टर्शरी के अंदर वो ट्रांसफ़र किए जाते हैं, भेजे जाते हैं। लेडी हेल्थ वर्कर्स भी इसमें इन्वॉल्व होती हैं, वो स्क्रीनिंग करती हैं घर 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 जाकर। उसके अलावा स्कूल के बच्चों में स्क्रीनिंग होती है, ठीक है। उसके लिहाज से इसमें जो मैंने किया था वो चकवाल के पीक प्रोजेक्ट में किया था। हमने क्या किया था कि प्रेवलेंस ऑफ मायोपिया हमने देखा था और एस्टिग्मेटिज्म की कौन सी टाइप कॉमन है। माई एम एंड ऑब्जेक्टिव वॉज प्रेवलेंस ऑफ मायोपिया अमंग चिल्ड्रन अटेंडिंग रूरल एंड अर्बन ऑप्टोमेट्री क्लिनिक्स, यूजफुलनेस ऑफ रेफरल मैकेनिज्म, लाइक वो किस रेफरल पाथवे के थ्रू उस ऑप्टोमेट्रिक क्लिनिक पर आए हैं और कौन सा रेफरल पाथवे जो है वो बहुत ज़्यादा कॉमन है। एंड द सेकेंड नेक्स्ट वन इज फ्रिक्वेंसी ऑफ रिफ्रैक्टिव एरर, टाइप एंड मैग्नीट्यूड ऑफ रिफ्रैक्टिव एरर एंड द टाइप ऑफ एस्टिग्मेटिज्म। द स्टडी डिज़ाइन जो था वो हमारा रेट्रोस्पेक्टिव डाटा था, बिकॉज जो ऑप्टोमेट्रिस्ट वहाँ पे काम कर रही थी 2022 के अंदर उन्होंने डाटा कलेक्ट कर लिया हुआ था। मैंने पीक सॉफ्टवेयर से वो डाटा लिया था, देन उसको एनालिसिस किया था हमने। जो मैंने जो डाटा फ्रॉम पीक सॉफ्टवेयर फ्रॉम सिटी हॉस्पिटल तालागंज जो अर्बन एरिया था एंड द RHC कोट काजी जो रूरल एरिया था। पॉपुलेशन हमने क्या किया था 5 ईयर्स टू 18 ईयर्स के दरमियान के बच्चों के लिए किया था। डाटा कलेक्शन मेथड वही जैसे मैंने आपको बताया कि पीक सॉफ्टवेयर के थ्रू मैंने किया था। इंक्लूजन क्राइटेरिया क्या था कि जो बच्चे थे 5 ईयर्स टू 18 ईयर्स तक, एक्सक्लूजन क्राइटेरिया और उनके अंदर रिफ्रैक्टिव एरर होना चाहिए। जो एक्सक्लूजन क्राइटेरिया था कि अगर फॉर एग्जांपल उन बच्चों में कोई पैथोलॉजी आ जाती है तो हमने उसको भी नहीं लिया, हमने सिर्फ रिफ्रैक्टिव एरर के बारे में देखना था। और अगर 18 ईयर्स से उनकी एज ज़्यादा हो गई तो वो भी एक्सक्लूजन क्राइटेरिया में। ड्यूरेशन मेरी क्या थी 1 जनवरी टू 31 दिसंबर 2022 का जो डाटा था वो एनालिसिस था। रिजल्ट क्या थे? जो रेफरल पाथवेज थे उसके अंदर कौन कौन से थे? कम्युनिटी स्क्रीनिंग थी, स्कूल स्क्रीनिंग थी और हाउस होल्ड स्क्रीनिंग थी। उसके अंदर जो सबसे कॉमन था वो क्या था? वो कम्युनिटी स्क्रीनिंग थी। 74.6 थी अर्बन में एंड 78.8 रूरल में थी। टाइप ऑफ रिफ्रैक्टिव एरर के अंदर मायोपिया की हाई प्रेवलेंस थी, जो अर्बन के अंदर थी वो हमारे पास 51.3% थी और रूरल के अंदर हमारे पास 59 थी। मैग्नीट्यूड जो था वो हमारे पास क्या था कि वो -1 तक का जो एरर था वो ज़्यादा था, ठीक है। ये हमारे पास अर्बन के अंदर था। रूरल के अंदर अगर हम देखें तो -1 टू -2 तक का जो एरर था वो ज़्यादा कॉमन था। टाइप ऑफ एस्टिग्मेटिज्म के अंदर हमारे पास जो सिंपल मायोपिक एस्टिग्मेटिज्म थी ठीक है, वो हमारे पास अर्बन के अंदर हाई उसकी प्रेवलेंस थी। और अगर हम लोग रूरल की बात करें तो उसके अंदर कंपाउंड मायोपिक एस्टिग्मेटिज्म की हाई प्रेवलेंस थी। कंक्लूजन क्या था कि एक तो मायोपिया की प्रेवलेंस सबसे ज़्यादा है, और जो हमारे पास रेफरल पाथवे है वो कौन सा ज़्यादा यूज़ है, वो कम्युनिटी रेफरल पाथवे यूज़ हुआ है। उसके अलावा हमारे पास आगे हमने क्या किया, इसके अलावा इसको हम बेहतर कैसे कर सकते हैं, वो ऐसे कि अगर हम लोग प्राइमरी आई केयर को है वो ज़्यादा बेहतर बना सके रूरल और अर्बन एरियाज़ में, सिंपल रिफ्रैक्शन से ज़्यादा इम्प्रूव करें। थैंक यू।
ये बेटा ये डाटा किसकी प्रॉपर्टी है? आपने उनसे इजाज़त ली है?
जी सर, पीक सॉफ्टवेयर मुझे दिया था डॉक्टर आरिफ सर के थ्रू।
अच्छा, ये
उन्होंने
जो
आपको टॉपिक दिया है?
अच्छा मुझे ये बताएं कि जो आपने प्रेवलेंस बताई है 51%, ये क्या कैसे आपने निकाला? जो ओवरऑल स्क्रीन आउट कैंडिडेट्स थे उनमें जो रिफ्रैक्टिव एरर था वो ये था, ओवरऑल पॉपुलेशन में तो नहीं है ना ये?
जो मेरे पास स्क्रीनिंग आई थी, जो डाटा मेरे पास आया था उसके अंदर जितने बच्चों के अंदर था वो था, क्योंकि मैंने खुद जाके डाटा कलेक्ट नहीं किया था, मुझे डाटा मिला था, क्योंकि 2022 के अंदर तो सब खत्म हो गया था ना, मैंने तो बाद में की थी रिसर्च।
ठीक है।
क्योंकि डाटा पहले से कलेक्टेड था, मैंने पास्ट डाटा लिया है, ठीक है, और उसके बाद रिसर्च किया कि पास्ट डाटा के अंदर जो डाटा था उसके अंदर मैं अब फ्यूचर में कर रही हूँ, मैं प्रेजेंट में कर रही हूँ, और डाटा भी 2022 का था, मैंने 2024 में किया।
आपने दूसरे लोगों का डाटा उठाया और उसको एनालाइज किया
जी।
तो ये रिट्रोस्पेक्टिव नहीं आता।
लेकिन
रिट्रोस्पेक्टिव में हम आउटकम और इफेक्ट देखते हैं पिछले बैक साइड में,
लेकिन
अभी आउटकम जो है उसको उसके साथ इफेक्ट को जो है उसके साथ कंपेयर
देखें, हम प्रेजेंट में गए हैं, डाटा तो मुझे 2022 का जो पहला था पुराना था ना, मैं प्रेजेंट में बैठ के पास्ट में डाटा कलेक्टेड था उसको करूँगी, ओके जो पास्ट में डाटा कलेक्टेड है मैं उसकी स्टडी करूँ प्रेजेंट में।
नहीं, आप बिल्कुल ठीक कह रहे हैं, लेकिन उसमें यह है कि जो आप डाटा एंड आउटकम की बात करें, बिकॉज इट वाज डाटा कलेक्टेड इन 2022, उससे आपने चूँकि रिजल्ट निकाला कि उनमें जो स्क्रीन आउट लोग थे उनमें क्या रिफ्रैक्टिव एरर्स थे, ये पहले डाटा एनालिसिस नहीं हुआ था, क्योंकि ये जो पीक का जो सॉफ्टवेयर का डाटा है ये असल में प्रॉपर्टी ऑफ COVS एंड पीक ऑर्गेनाइजेशन है।
मैडम रेट्रोस्पेक्टिव में तो हम एक्चुअली अभी का जो डाटा है ये भी लेना है और
पुराना
जी जी एग्जैक्टली
कंपेयर करना है।
ऐसे तो नहीं कि आप पुराना
नहीं,
डाटा
बिल्कुल आप ठीक कह रहे हैं।
एनालाइज करो।
जो वो कहना चाह रहे हैं कि आप अभी भी करें
तो
जो,
फिर इनको compare
और उन दोनों को कंपेयर करें कि 2022 में क्या सिचुएशन थी और अब क्या आ रही है। तो अब आप यूँ करें कि जो अभी आप करेंगे ना उसके साथ नेक्स्ट में आप कंपेयर कर लें।
मतलब इसको कर लेंगे कंपेयर, क्योंकि हमारी तो ऑनगोइंग रिसर्चेस होती है तो उसमें हम इसको ऐड कर लेंगे।
ठीक है, चले। नेक्स्ट प्रेजेंटर इज सबा गालिब। सबा गालिब अवेलेबल हैं? नहीं है। अच्छा जी, जोहा नवीद आए हैं। Her topic is comparative study of intraocular pressure in type 2 diabetes mellitus patients and non-diabetic patients.
Assalamu alaikum. My name is Suhan Naveed and I am a graduate of FMH College of Medicine and Dentistry. The topic I am going to present today is a comparative study of intraocular pressure of type 2 diabetes patients and non-diabetic patients. To get into the topic, we first need to discuss that what basically diabetes is. Diabetes is a chronic condition where the body has too much glucose in it, mainly because of two reasons. Either the insulin is not being produced or the produced insulin is not effectively being used in the body. The latter is the reason why type 2 diabetes is being caused in the body, because the body cells become resistant to the insulin. When the body becomes resistant to the insulin, it causes a lot of complications not only just in the body but also in the eye. Most commonly eye conditions related to increased diabetes is diabetic retinopathy, cataracts and glaucoma. I will specifically be discussing about the glaucoma because that is caused by the high IOP. Now, the question arises that how diabetes causes the raise in the IOP. Here are two pictures that demonstrate it. In the first picture, you can clearly see that how aqueous humor is been draining from the trabecular meshwork. Trabecular meshwork is a net-like structure from which the aqueous humor is flowing. In the second eye, you can see that that is a glucomatous eye, and due to the blockage of the trabecular meshwork, that can be due to glucose molecules, the aqueous humor gets stored inside and raises the IOP in the eye. Specifically the glaucoma that is caused by the increased diabetes is neovascular glaucoma. Hence, that brings me to the objective of my study, which is to compare the intraocular pressure between type 2 diabetic patients and non-diabetic patients. I used 184 patients. It was an observational case control study, and the duration of the time was 4 months after the approval of the synopsis. The data was collected in FMH College of Medicine and Dentistry, and later it was analyzed by SPSS. The test that I used for the analysis of the data was a T-independent test. Coming up to the methodology, firstly I collected the demographic data of the patients. Later I recorded the visual acuity of the patient and what is the type of the diabetes that they are facing and from how long they are facing that diabetes issue. Later on, the intraocular pressure was checked by the aplanation tonometer along with the dilated fundus examination that was performed under the supervision of an ophthalmologist. My results clearly showed that most people that were diabetic and were included into my sample size fell into the category which was 30 to 40 years old, and the least patient that were included into my study were 60 to 70 years old. Here is a pie chart in which you can clearly see that 57.6% of the people were those in my study that were diabetic, which actually shows us that how diabetes is one of the growing disease in the growing population. Now I have compared here that no matter if the person is diabetic since 2 years or 3 years or either 5 years, you can see that the IOP, the mean average of those all patients remains similar, which is 15 mmHg, and that is all the same for all the durations, whether the patient is diabetic from 2 years or up to 5 years. Lastly, this is the conclusion of my study where I have compared the diabetic males with the non-diabetic males and diabetic females with the non-diabetic females. You can clearly see that the diabetic males have the IOP in the range 15 to 16 mmHg, whereas the non-diabetic females have their non-diabetic males have their IOP from 12 to 13 mmHg. Likewise, the same pattern is been followed in the non-diabetic females have the IOP in the range 11 to 13 mmHg, and the diabetic females have their IOP in the range from 15 to 16 mmHg. That brings me to the conclusion of my study, which is that there was a consistent relationship between diabetes, type 2 diabetes and higher intraocular pressure, irrespective of the age, gender and the duration of the diabetes. My p-value were lesser than 0.05 and that's why the results were highly significant. Thank you. Any questions are more than welcome.
IOP के लिए कट ऑफ रेंज क्या ली थी? IOP के लिए आपने कट ऑफ रेंज क्या ली थी? मतलब 11 से हायर होगा, दैट वुड बी कंसिडर्ड एबनॉर्मल या रेज्ड? उसका कोई रेफरेंस है आपके पास कि आप 11 मिलीमीटर ऑफ मर्करी को एज रेज्ड IOP कंसिडर करें?
No, sorry, I want to say कि 11 mmHg हम लोगों ने जो कट ऑफ वैल्यू लिखी था, 11, that was basically 13. अगर 13 से above वाला था, क्योंकि मिनिमम जो IOP होता है that is 12 to 22 mmHg.
जी.
तो बेसिकली हम लोगों ने ये किया था कि अगर 13 से above आ रहा है तो we consider it as raised than the normal value.
नहीं, 13 तो ऑलरेडी उस कट ऑफ रेंज में फॉल कर रहा है, क्योंकि रेज्ड IOP जो होता है उसको सिंगल हैंडेडली नहीं कर सकते. इफ़ यू हैव रेफरेंस अवेलेबल कि आप रेज्ड IOP की ये वैल्यू है, बिकॉज 13 इज़ फेयरली नॉर्मल IOP.
Yes, that is. But basically my study was that कि अगर थोड़ा सा रेज भी आ रहा है, even 15 to 17 mm mercury is considered to be normal. But what we want to say कि diabetic patients में comparatively थोड़ा सा ज़्यादा होता है. That can create a problem later on in life.
नहीं ठीक का इशू नहीं है एग्जैक्टली नहीं ग्लूकोमेटिस की बात नहीं है क्योंकि 13 जो है इज relatively considered as a normal IOP considered in normal population whether diabetic or non-diabetic ठीक है आप वैसे कह सकते हैं कि they have relatively higher values of IOP in diabetic patient as compared to non-diabetic but still they are falling in the normal category of IOP.
I guess I didn't mention it in the field but that is what I exactly meant कि वो थोड़ा सा हायर ज़रूर है लेकिन दैट इज़ इन द नॉर्मल रेंज.
बेटा एक्चुअली नॉन टेंशन नॉर्मल टेंशन ग्लोकोमा डिफरेंट है.
हाँ जी.
लेकिन जो ग्लोकोमा को उसको हम हर आई का डिफरेंट होता है लेकिन 20 से ऊपर को ज़्यादातर 20 से ज़्यादा को लेते हैं.
जी जी.
यानी वो तो डिफरेंट स्टोरी है. ये बताइए कि रीज़न क्या है इसका हाई होने का डायबिटीज़ में? क्या आपको इसका रीज़न लगा है? वाई इट इज़ सो?
Why intraocular pressure is higher in diabetic patients?
सर
जब बेसिकली ये होता है कि आपके जब ग्लूकोज अगर डायबिटीज़ तो आपकी मैनेज नहीं है तो ग्लूकोज मॉलिक्यूल्स जो हैं वो आपके ट्रबैकुलर मैशवर्क को ऑक्लूड कर सकते हैं जिसकी वजह से एक्वस ह्यूमर का फ्लो जो है वो ऑब्स्ट्रक्ट हो सकता है. सेकेंड रीज़न ये होती है कि जो न्यू वेस्कुलर ग्लूकोमा हमारे पास स्पेसिफिकली कॉज होता है दैट इज़ कॉज्ड बाय द इस्कीमिक रेटिना. तो उसमें ये होता है कि क्योंकि रेटिना स्टार्ट्स प्रोड्यूसिंग वेजेफ और फिर वेजेफ की प्रोडक्शन की वजह से वहाँ पे नियोवेस्कुलराइजेशन होने लग जाती है. दैट आल्सो ऑक्लूड्स द ट्रबैकुलर मैशवर्क.
वो नियोवेस्कुलराइजेशन एट द लेवल ऑफ ट्यूबरकुलर मैशवर्क जो है वो ग्लोकोमा करता है.
यस एग्जैक्टली.
लेकिन उसका उससे ताल्लुक नहीं है डीआर से डायबिटिक रेटिनोपैथी से नहीं है रेटिना की. ये उसकी अलग है.
बेटे जो आपने डायबिटिक पेशेंट्स लिए थे वो कंट्रोल्ड डायबिटिक पेशेंट्स थे या अनकंट्रोल्ड थे या दोनों कंबाइंड लिए थे?
कंबाइंड लिए थे.
अच्छा उनका आपने बेसलाइन चेक किया?
आपका बाइसनेस आ जाएगी ना बिकॉज अनकंट्रोल्ड डायबिटीज में रेज्ड लेवल इज डिफरेंट मीनिंग देन कंट्रोल्ड डायबिटीज विद रेज्ड लेवल्स. आई थिंक आपको उसमें थोड़ी सेग्रीगेशन करनी चाहिए.
एग्जैक्टली. हाँ जी.
और उसके लिए आपको यू हैव टू सेट ए वैल्यू फॉर ग्लूकोज लेवल्स के आप किन ग्लूकोज लेवल्स को कंट्रोल डायबिटीज कंसिडर करेंगे और किनको अनकंट्रोल कंसिडर करेंगे.
उसमें ये है कि जब अनकंट्रोल्ड होगा तो उससे फिर लेंस भी स्वेल कर जाता है वो सॉर्बिडोल पाथवे
एग्जैक्टली और भी कॉम्प्लिकेशंस होंगे
तो उसकी वजह से भी रेज आ सकता है.
जी जी श्योर. ओके थैंक यू सो मच.
चलो थैंक यू जी. आवर next speaker is Mr. Asadullah and his topic is effect of corneal astigmatism on retinal nerve fiber layer thickness using optical coherence tomography.
My next presentation is on the effect of corneal astigmatism on retinal nerve fiber layer thickness using optical coherence tomography, that is OCT. Before moving to the core of my study, I would like to briefly highlight why retinal nerve fiber layer is important. The retinal nerve fiber layer is made up of unmyelinated axons of retinal ganglion cells, and any structural changes here directly affect the visual signal transmission to the brain. In clinical practice, RNFL thickness is one of the earliest indicators for conditions such as glaucoma, optic neuritis, and other neuro-ophthalmic disorders. Today, spectral domain OCT is the gold standard for evaluating the retinal nerve fiber layer because of its excellent resolution and reproducibility. However, it is important to remember that OCT measurements are not immune to optical influences. Factors like axial length, refractive errors, scan centration, signal strength, and corneal curvature can all alter the apparent RNFL thickness. One of the factors that has gained increasing attention is corneal astigmatism. Astigmatism induces directional differences in corneal curvature, which means the optical power of the eye is not uniform across all meridians. Because of this, OCT scans may experience meridional magnification differences. In practical terms, this can distort or shift the circular OCT scan around the optic nerve head. It can also reduce the localized signal's quality if one part of the scan falls out of focus. As a result, RNFL thickness may appear thinner or thicker in specific quadrants, creating an artifact that can mimic true pathology. Astigmatism is also extremely common, affecting 30 to 60% of the global population. Higher degrees of astigmatism are specific axes like with the rule, against the rule, or oblique may have a more pronounced effect on the OCT readings. Several studies have explored this relationship, but these findings so far have been inconsistent. Some report significant RNFL thinning with increasing astigmatism, particularly in certain quadrants, while others find minimal or no association. Another important point is that most of these studies have been conducted in East Asia or Western populations. There is very limited evidence from South Asia where patterns of corneal astigmatism may be different due to genetics and environmental factors. Given that RNFL assessment is central to diagnosing and monitoring optic nerve disease, even small measurement errors can influence clinical decision making. This led us to our study objective to evaluate whether corneal astigmatism affects average and quadrant specific RNFL thickness in healthy non-pathological eyes in the Pakistani population using spectral domain OCT. Moving on to the methodology of our study, we began with a sample hypothesis. The null hypothesis stated that the corneal astigmatism does not influence RNFL thickness measurements on spectral domain OCT. In contrast, the alternative hypothesis proposed that corneal astigmatism does have a significantly effect and may cause measurable variations in RNFL thickness. To test this, we concluded a comparative cross-sectional study at the Ophthalmology Department, Hyderabad Medical Complex, Peshawar. The study spanned 18 months from August 2022 to January 2024. For sample size estimation, we use G-Power software with a effect size of 0.5, a confidence interval of 95% and a power of 80%. The calculated sample size was 134 participants. To increase the reliability, we recruited a total of 176 participants, 88 in each group. A consecutive non-probability sampling technique was used. Participants were divided into two groups, those with low or no corneal astigmatism, defined as 1 diopter or less, and those with a high astigmatism ranging from 1 to 7 diopters. The group were matched for both age and gender. We applied strict exclusion criteria, removing individuals with glaucoma, retinal diseases, history of ocular trauma or surgery, corneal opacities, systemic illness like hypertension and diabetes, as well as any neurological disorder or optic neuropathies. The study protocol was approved by Institutional Review Board of Hyderabad Medical Complex, and written informed consent was obtained from each participant. The objectives and examination steps were explained clearly, and all procedures followed ethical guidelines. For data collection, we used a structured clinical proforma. Visual acuity was measured at a distance of 6 meters using Snellen chart. Refraction and keratometry were performed using a Topcon KR 8900 with three reading taken for reliability. Central corneal thickness was measured with the PACMAT DGH 55 ultrasound pachymeter. RNFL parameters, both average and quadrant thickness, were obtained using the Cirrus HD OCT 5000. We ensured correct fixation, centration, and signal quality for all OCT scans to minimize measurement errors. For data analysis, we use SPSS version 25. Normality of the data was checked using the Shapiro-Wilk test, and results showed that all variables were non-normally distributed. To compare RNFL thickness between the low and high astigmatism groups, we used a Mann-Whitney U test and also calculated effect sizes to assess the magnitude of differences. Quadrant-wise RNFL comparison within each group were analyzed using the Friedman test, followed by Bonferroni adjusted post-hoc test to control for type 1 errors. Finally, the correlation between the corneal astigmatism and RNFL thickness, both average and quadrant specific, was examined using Spearman's rank correlation. A p-value of 0.05 or less, which was considered statistically significant with adjustment applied where multiple comparisons were made. So now coming towards the results, this table shows the baseline demographic and refractive characteristics of our study participants. We enrolled 176 participants equally divided between the low and high astigmatism groups. The median age was 23 years with an interquartile range of 18 to 32, and there was no age difference between the groups. Gender distribution was also identical with about 57% females and 43% males in both groups. In terms of refractive status, Myopia was the most common, accounting for about 78% of the eye, followed by hyperopia and smaller proportion of emmetropia. Importantly, the distribution of refractive errors was not significantly different between the two groups. Overall, this table confirms that both groups were well matched at baseline, allowing for a fair comparison of RNFL measurements. This table summarizes the comparison of corneal astigmatism and RNFL thickness between the low and high astigmatism groups. In total sample, the median corneal astigmatism was about 1.06 diopters, but when divided into subgroups, the low corneal astigmatism group had a much lower astigmatism, around 0.5 diopters, while the high CA group, corneal astigmatism group, averaged 1.5 diopters. For RNFL measurements, we found a consistent pattern. The low astigmatism group had a thicker RNFL values across all parameters, including the average, superior, inferior, temporal, and nasal quadrants. For example, the average RNFL was 116 micron in the low corneal astigmatism group compared to 112 microns in the high corneal astigmatism. Similar differences were seen in all four quadrants. Overall, this table clearly shows the higher corneal astigmatism is associated with thinner RNFL measurements. To compare RNFL thickness between the low and high corneal astigmatism groups, we applied the Mann-Whitney U test due to non-normal data distribution. The results showed statistically significant differences across all RNFL parameters, that is, p-value is less than 0.001. Eyes with low corneal astigmatism had thicker RNFL values than those with high astigmatism in the average measurements as well as all quadrants, that is, superior, inferior, temporal, and nasal. To assess differences between, across the four quadrants within the whole sample, we applied the Friedman test. This showed a significant variation among quadrants, with the inferior quadrant being the thickest, followed by superior, nasal, and temporal quadrants. These results confirm the effect of corneal astigmatism or RNFL thickness and the normal anatomical variation across quadrants, which also follow the agent rule. To further explore RNFL differences across quadrants, we performed post-hoc pairwise comparison using the Wilcoxon sign rank test with Bonferroni correction. The results showed significant differences between almost all quadrants with p-value less than 0.001. Specifically, the inferior RNFL was thickest, significantly greater than superior, nasal, and temporal quadrants. The superior quadrant was thicker than the nasal and temporal quadrants. The nasal RNFL was thicker than temporal quadrant. These findings confirm the normal anatomical pattern of RNFL thickness, with inferior and superior fibers being denser compared to nasal and temporal fibers, which is consistent with the known retinal anatomy. We also evaluated the relationship between the corneal astigmatism and RNFL thickness using Spearman's rank correlation. The analysis revealed a strong and statistically significant and negative correlation across all quadrants and the average RNFL with p-value less than 0.001. Specifically, the strongest negative correlation was seen in the temporal and nasal quadrants. The superior and average RNFL also showed strong negative correlation. The inferior quadrant had the weakest yet still strong negative correlation. In other words, higher corneal astigmatism is consistently associated with the thinner RNFL, confirming that corneal optics may influence OCT measurements. In conclusion, our study demonstrates a strong and significant negative relationship between the corneal astigmatism and RNFL thickness. Specifically, higher corneal astigmatism is associated with thinner RNFL in all quadrants. We also observed that the inferior and superior quadrants consistently have thicker RNFL than the nasal and temporal quadrants, reflecting normal anatomical variation. These findings highlight the importance of considering corneal astigmatism when interpreting OCT RNFL measurements, particularly in patients with moderate to high astigmatism, to avoid potential diagnostic errors. Overall, this study provides quantitative evidence that can aid clinicians in improving the accuracy of RNFL assessment in astigmatic eyes. These are some of my references, and this study has, I have submitted it to American Journal of Ophthalmology, and it has been accepted and will be published soon. Thank you.
Very good.
ये आपने जो ग्रुप बनाए हैं एक -1 तक और उसके बाद -1 to -7 तक या 10 तक, अच्छा ये ज़्यादातर जो इफेक्ट पड़ता है वो -3 से ऊपर पड़ता है, जो लोअर है उस पर तो फ़र्क पड़ता है, लेकिन बड़ा थोड़ा पड़ता है। तो आपने -1 तक ग्रुप क्यों रखा है? वाई नॉट हायर देन दैट?
इससे रिलेटेड मैंने कोई स्टडी नहीं देखी जिसमें 3 से ऊपर का कहा हुआ हो कि 3 से ऊपर पे इफेक्ट पड़ रहा है उससे नीचे
नहीं पड़ता है, वो तो 1 का भी पड़ेगा, लेकिन जो मेजर इफेक्ट्स पड़ते हैं दैट्स अबव -3।
एक्चुअली सर मैंने ये इस बेस पे लिया कि हम 0.7 तक जो एस्टिग्मेटिज्म होता है सेनेटल, तो वो हम माइल्ड एस्टिग्मेटिज्म में लेते हैं, तो इस वजह से मैंने माइल्ड को अलग किया और बाकी मॉडरेट और सीवियर को अलग किया।
ठीक हो गया, थैंक यू वेरी मच। Now our last presenter is Miss Fiza Batul and her topic is the complexity of coexistence.
Assalamu alaikum. I am Fiza Batul, PGR Orthotics Department, King Edward Medical University, Lahore. I am here to present a rare case report that shows the complex coexistence of two conditions. Before moving forward, I would like to clarify that all the information that I will share here is with the patient consent. Now move forward to the patient profile. A 32-year-old male referred from the neurologist presented in the orthoptics clinic with the drooping of upper eyelids that was more pronounced in the left eye as compared to the right eye, along with the diplopia for the last 3 months. He also experienced his first episode of diplopia 3 years back in 2022, and he also mentioned that the symptoms were highly fluctuating and tending to worse as the day progressed. And when we further proceeded in the procedure of history, we found out that patient have history of inherited hemophilia as well. A thorough examination of patient was carried out that was started with the ocular examination. As we can see, visual acuity of the patient was taken unaided as the patient was not using any sort of spectacles, and it was 6 at distance and N6 at near. Pupils were round, regular and reactive, and fundi of both eyes were appearing normal. After the sensory evaluation of patient that included fusion and stereopsis was conducted. On fusion with word for dot test, patient experienced diplopia, while on stereopsis patient with using Lang's and Frisbee test reported no stereopsis. After this motor assessment was conducted and squint was measured through the prism cover test, and as the table depicts, at 1/3 meter when we made him fixated with the right eye, left exotropy and left hypertropy of the patient was measured, and when he fixated with the left eye, right exotropy and right hypertropy of the patient was measured, and chin elevation was observed as abnormal head posture. Ocular motility of the patient was highly restricted in all the muscle plane in either eye, and on diplopia charting, patient experienced diplopia in all the gazes except for primary gaze. Ptosis evaluation of patient was done elaboratively as the patient's chief complaint was drooping of both eyelids, and a few parameters are highly valuable in this data. As we can see, Bell's phenomena that was poor in right eye and absent in the left eye. Fatigability was positive in both eyes. Cogan's slit twitch test was also present in both eyes, and diurnal variation was also positive. And one point that I will mention here, that patient measurements were highly fluctuating throughout the examination. After thorough ocular examination, further investigation that included lab investigation, neurophysiological evaluation and radiological investigations were also carried out to further support the diagnosis. And lab investigation were yielded normal result, especially including serum acetylcholine receptor antibodies and anti-musk receptor antibodies. Neurophysiological evaluation that included EMG, electromyography and nerve conduction study also normal. Radiological investigation that included MRI brain was totally unremarkable, and CT chest with contrast also showed no evidence of thymoma. After considering only the ocular symptoms of the patient, we identified 3 possible conditions as a differential diagnosis that included ocular myasthenia gravis, chronic progressive external ophthalmoplegia and thyroid eye disease. But after comprehensive investigations, we came out with a final diagnosis as double seronegative ocular myasthenia gravis. As an orthoptic personnel, we kept him on observation and also guided him for the PRISM trial after getting his squint stabilized first, and referred him to the ophthalmologist. He also seconded our opinion and medically managed him with the tablet Amegra and Delta Cortrel and Prizic, and surprisingly after 2 weeks patient's symptoms were significantly improved. This is the pictorial presentation of my patient. The first picture is of the patient at the first day of examination, and the second picture is at the first follow-up. Previous literature have reported a single case report that linked two conditions that were ocular myasthenia gravis and acquired hemophilia back in 2011. That is quite justifiable because both conditions have similar autoimmune mechanism. But this case study is different in a way that patient is having ocular myasthenia gravis in the presence of inherited hemophilia. So further studies are needed to determine whether this coexistence is truly exists or just a coincidence. These are the references of the literature, and this study was done under the supervision of Madam Aisha Sarfraz, senior orthoptist at Mayo Hospital, Lahore, and that was all from my case study. Thank you.
Any questions from the audience regarding this case study? Thank you very much. This brings us to the conclusion of this session, and obviously it was very thought-provoking, and I think that the audience must have learned some new things as well. Now I would like to request the chair and co-chair of this session to give the final remarks.
Every study brings some new ideas to go further for in the obviously the field of research, but I would like to highlight, because we are presenting some research, you should stick to some few rules like your conversation, language, time, and crowding of slides. Otherwise, every research provided a new insight to me just for after listening. So we can go further for deep digging. In one thing I would like to highlight: whenever you go for some research, always don't take parameters shallowly. Always have some deep insight of all the parameters. Like you did research on diabetes, because although it was a very good study, but we don't have any detailed data whether diabetes was controlled or uncontrolled. So like few deep parameters could impact your study and treatment guidelines.
देख लिया करें, रिहर्सल किया करें, देखें आपका टाइम जो है उसके मुताबिक है. आज तो इत्तेफाक से हमारे पास टाइम था, क्योंकि कुछ हमारे जो थे प्रेजेंटर्स वो नहीं आए थे, वगरना फिर मुश्किल पेश हो जाती है और आपको अपना पूरा पेपर प्रेजेंट करने का मौका नहीं मिलता.
So actually we started when presenting in OSP, it was just 3 minutes, and we rehearsed multiple times before presenting. उसमें ये होता, you have to highlight the main points. One thing I would like to suggest कि don't get deep into the introduction of the topic, because everybody knows basic information about your introduction, like what is low vision, what is RNFL. Mostly you can just highlight a single definition baseline, and that's all. It's in this way you can somehow squeeze your time for your presentation as well.
Apart from that, you should keep 7 to 8 slides maximum and give 30 seconds to each slide. So like this you can finish in the time. So you should also keep 30 minutes for question and answers if it's so.
So you have to modify your presentation on the guidelines and the steps, information provided by the conference organizing scientific committee. So these guidelines are particularly guided by the OSP scientific committee, or you can check whether you are presenting some other conference, whether what guidelines are they are providing through their scientific committee. And you, आपके तो टॉपिक तो वैसे ही बहुत इनोवेटिव थे.
So thank you very much, and we can have photograph.